Good afternoon, everybody, and I'd like to warmly welcome you all to this plenary, which is the 6th and the final live plenary of this year's Health Service Research UK conference. My name's Jenny Whitty, and I'll be chairing this afternoon's plenary with you today. And our plenary topic today is new approaches to data analytics. So the capacity to analyse data in near real time is changing our ideas of the role and the nature of quantitative research, and opening up its potential for contribution to decision making. And thinking about approaches to how we can do this has never been more important than it is now in the times of the current pandemic. So we have two speakers for our plenary today who will share their experiences and their insights with us. Our first speaker is Adam Steventon. Adam is Director of the Data Analytics at the Health Foundation, where he has established an innovative team that use data to tackle pressing problems affecting the health of the UK. And together with his team, Adam champions better data analytics across the health and the social care system. Our second speaker will be Ronan Lyons. Ronan is Clinical Professor of Public Health at Swansea University Medical School, an honorary consultant in public health with Public Health Wales NHS Trust, and an adjunct professor at Monash University in Australia. He's also currently the Research Director for Health Data Research UK and Co-Director for the SAIL Data Bank. So each of our speakers will speak for about 15 minutes with one presentation following on directly from the other. And at the end, we will then have time for a discussion when the speakers will be able to respond to your questions. So I would ask you and encourage you to please send questions for our speakers and our presenters throughout the plenary. And you can do this using the Q&A option that you find at the bottom of the Zoom taskbar. And you can also upvote questions that other people have put, which will make them raise to the top if you show your support for other people's questions. And you do that using the thumbs up icon if you haven't used it before. So now I'd like to invite our first speaker, Adam, to give his presentation.
Thank you. Well, can I start by congratulating the conference organisers? Not only has this been a remarkable achievement at a difficult time, but it also represents an important step forward. The complexity of the challenges facing health services means that more than ever, a multidisciplinary approach is needed, including not only health services researchers, but computer scientists, sociologists, practitioners, patients, voluntary groups, and even over the last few months, defence teams. My hope is that the virtual nature of this conference has enabled more people to be involved than ever before, and this will benefit us all going forward. I've set myself a challenging task for the next 15 minutes, which is to reflect on how data has been used during the pandemic and draw out some of the lessons for health data researchers, data scientists in industry and the voluntary sectors, and technologists. We are, of course, still in the thick of it. And I don't know about you, but my thoughts about the pandemic are changing on a daily basis. Some days are better than others. I hope my remarks will be taken for what they are, exploratory, and I'm looking forward to a discussion later and learning from everyone. So let's start with some observations about how data has been used over the last few months. Well, first and most significantly, there has been much greater public engagement with data. There's a thirst for data. The number of positive cases has been a topic of household debate. Guides are being published in our newspapers about epidemiological concepts. And importantly, there's interest in missing data, what the data doesn't tell us, what we don't know. Data has contributed towards national decision-making as never before, as we've seen in the daily government briefings. And I think it's remarkable how the health services research community has reorganized itself to feed into groups such as SAGE, and importantly into other channels too, including media. We've seen remarkable innovation. Things that used to take months or years are now happening in weeks or days. The Office for National Statistics has been incredible, and the recovery trial has been a highlight, an initiative that benefited from the investment made by HSR UK and NHS Digital. However, and importantly, we've seen much less innovation in other areas, perhaps because there was less prior investment. And it seems to me there's sometimes a mismatch between where the innovation is happening and where the need is. And I wanted to take the opportunity to highlight the need to make much more rapid progress on social care data. Social care has been hit profoundly by the pandemic. The figures are, quite frankly, horrifying. 12,000 deaths amongst care home residents in 2 months, 4,500 deaths among people using social care at home, and these deaths have not reduced nearly as quickly as the care home deaths. There's been an untold impact on care workers. And I'd like to argue that our data system has failed social care, and we can't be in the same position for the next wave. Of course, the social care system is complex, and the problems with social care data are complex too. And we've been exploring these topics in partnership with Future Care Capital. You might be interested to see the blog that we published on our website yesterday. Of course, many ethnic groups have been hit particularly hard by the pandemic too, and the Black Lives Matter movement has quite frankly given us all a much needed wake-up call, a point that I'd like to return to. But what does this all mean for health data researchers, data scientists, and technologists? And I'd like to suggest there are 5 priorities. First, we need to make suffering visible. We knew going into the pandemic that people with learning disabilities are at increased risk from infectious disease. That's why we offer free flu jabs. But more than 4 months in, we still have little data on how people with learning disabilities have been affected, as the excellent blog by Chris Hatton shows. As a result, it's been harder for people with learning disabilities and their allies to marshal action. Why is this? This question, which can be asked for many other groups of people besides people with learning disabilities, raises a profound challenge for anyone who's interested in the use of health data. After all, we're increasingly reliant on data that's being collected through digital systems, which are shaped by practical economic, political, and social considerations. And one takeaway is that missing data is not just a technical issue. It's not just about multiple imputation. It's a matter of priorities, and it has consequences. And we should, I believe, as a community, be talking much more about primary data collection, but we should also be asking why some groups are reluctant to share data with us. Second, public and patient involvement and engagement needs to become the norm for health data projects. There are many reasons to do this. One compelling reason is that it makes for a better product. Nowhere is this clearer than in the contact tracing app. A lot has been written about the app, but for today, I just wanted to make 2 points about it. First, there was a rationale for developing the app. Coronavirus spreads quickly, and we don't always know who we are infecting, so automated contact tracing is potentially beneficial. Yet the app failed, at least in its first incarnation, in large part due to concerns amongst the public about how the data would be used and whether the app was even the right solution. These problems could have been avoided with more genuine public and patient involvement structured around issues that matter to them. And let me tell you, this does not come naturally to data people. At the Health Foundation, we've been pushing ourselves to develop our own practice in relation to public and patient involvement. And the weak notes that I've linked to on the right will give you the warts and all story. It's hard, but it's worth it. And thankfully, there are loads of resources to draw on. The third priority, I think, is that we need to make open analytics the norm. A recurrent theme over the last few months has been that data teams, decision makers, and the public have not been able to access the data and tools they need to do their work. This has led to confusion, wasted resources, and poor decisions. And it means that collectively, as a health data research community, as well as the data scientists and technologists, we are not having the impact that we should. Many different views are being put forward about what happened in Leicester, who knew what when. But the fact that questions are even being asked about what data were available shows that we are not where we need to be in terms of open data and open analytics. Fourth, we need to address the unequal benefits of data and technology. And of all of the things that I like to explore today, This is by far the hardest and the most complex, and I don't pretend to have the solutions or even a good understanding, but I do think we need to talk about this more. It seems to me that the use of health data in all of its forms is having, at best, a small positive impact on health inequalities, and more likely, a negative one. And why do I think this? Well, for one thing, there aren't many examples of data being used to create understanding. Even the Public Health England report, which many of you will be aware of, and which contains some useful analyses and added to the debate, still did not manage to create much understanding about health inequalities without the qualitative work alongside it. To give another example, one that's more about technology, our polling done at the Health Foundation revealed that people in lower paid jobs were much less likely to say they would download the contact tracing app, despite being arguably at more risk of the disease. And it seems to me that many examples of health data technologies are not being designed in a way that meets the needs of the people who most need them. No doubt there's a lot that needs to happen here, but I'd like to take a moment to raise the critical issue about the diversity of all of our teams at all levels. Without more diversity, we'll continue to ask the wrong questions and develop the wrong products. It's easy to make this about someone else, but it isn't just about the diversity of big tech. It's about the diversity in academia, charities, and the NHS too. It's about our own organizations. Finally, and this is the broadest point I'd like to make, we need to be thinking much more critically about how data is changing the world. For example, for many people over the last few months, access to basic necessities such as food and coronavirus tests have depended in large parts on the results of data sharing. And there's no doubt plenty to celebrate here, as data has been used to get necessities to people rapidly at a time when they've needed it most. But many people are fearful of sharing data, and for good reason. And there are questions about the categorizations used by data scientists and researchers, particularly the definitions of vulnerability that have been used, and whether these definitions reflect how people see themselves, and indeed their level of need. My conclusion here is that health data researchers, data scientists, and technologists need to engage much more critically with questions around how data and technology are shaping the world. Conversation about data is a conversation about people and the world that we're creating. And I've learned a lot from the Kate Crawford talk that I'd encourage you to all take an hour to listen to. I'd like to end with some practical suggestions for what we can all do to respond to some of these challenges, because there is something we could all do. How, as researchers, do we help make suffering visible? Well, besides prioritizing new data collections, we could reconsider how we are going about our subgroup analyses. We can only do so many of them, but it's a matter of priorities. Where do we put our statistical power? Second, in relation to public and patient involvement, well, a good thing to do here to get started is to speak to a patient. And if this is scary for you, then ask somebody else to join the conversation to support you. You might enjoy it, and perhaps going forward, you might even want to put as much effort into building your patient network as you do your professional one. On open analytics, well, we should all consider using preprints and publish our code on GitHub. Many other disciplines do this, but it's not common in health data. And perhaps we should even consider publishing our code before our journal articles are published, as this will help other data teams see what we're doing and to learn from what we're doing. We'll all produce better science if we share and collaborate more openly. On equal impacts, we should educate ourselves and have better conversations. And finally, let's be relentlessly curious about how data is shaping the world around us. Thank you very much for listening. I'm eager to hear your questions, but first we'll turn over to Ronan Lyons.
Okay, hello. I think I'm on now. So, well, thank you very much for asking me to speak here. I'm delighted to be able to talk at this conference, and I'm going to talk quite a bit about developments, about groups working with data, and then also show some data analysis as I go on. I have to say I very much agree with all of the comments that have just been made, and you'll see that we're probably singing, but from the same hymn sheet. So if I just, there we are, move on to the next slide, really. So my job is I'm Professor of Public Health at Swansea University. I come from a medical background. I used to work in emergency departments, but I've been involved in population health research for a good number of years. Sometimes there's this false dichotomy between health services research and public health, one which I don't agree with. There's a very good Institute of Medicine report from 2002, which looks at this in detail. So I'm interested in improving population health outcomes at scale. And I don't really care whether those happen through clinical outcomes in the NHS and other organizations or through non-clinical approaches with the general population. One thing, as I said, we do use data that are collected by the NHS. And before I get into this, I'd particularly like to pay tribute to the Understanding Patient Data Initiative. The fact that the data collected by the NHS on millions of patients has been made available in a de-identified form through privacy protected environments to allow us to be able to undertake some of this research. One of my jobs, as Jenny pointed out early on, is I work for a relatively new organisation, Health Data Research UK, which has come together and been funded by the main, if you like, health funders in the UK and the various governments across the UK. And so what that's been doing is discussing and bringing together the data controllers in the Health Data Research Alliance, creating some research hubs which would then use the data in a trustworthy manner, build on those tools which discover, de-identify, link and access data, and make all of this a bit easier. So Health Data Research UK has a number of technical work streams and then some of the practical ones. The practical ones really fit under the using health data. And there are four particular aspects of that. There is the understanding the cause of diseases, better, faster, efficient trials. And so one of the people who's involved and who leads the trial end is Martin Landry from Oxford, who was involved in that recovery trial. I lead the Improving Public Health Initiative across the UK, and there's also a Better Care Initiative, which is very closely allied to health services research. And of course, on top of that, there's an entire training and skills development program so that we're developing the sort of people who can actually use these complex data sets. The public health strategy is based around four particular pillars. The first, what we're attempting to do is to develop privacy protecting population cohorts derived from routine data right across the UK, 68 million people. And I'll mainly talk about that. I've just gone one ahead there at this stage. There is yeah, thank you very much. There's another part which is about maximizing the utility of traditional cohorts. About 2.5 million people in the UK have joined cohorts like Understanding Society, UK Biobank and that. And to make best use of those for population health reasons, we need to efficiently link them to routine and other administered data, and also then provide greater access to the research community through multi-cohort platforms. A third component is about a lot of the analytical methodologies really need to be improved and fit for purpose for dealing with longitudinal, complex, multimodal data. And of course, we need to train the workforce that can use both the data and the tools that are being created. Just to point out now that we have a public health national team. We managed to get about 1/3 of them to a meeting in London before COVID. So this is one of these strange photographs you can now see where people are grouped together. There are people from right across the 4 nations, and I'm going to present quite a bit of their work. One of the tasks which HDR UK has taken on itself in recent weeks is, since COVID, to provide a weekly update to SAGE on what data sets are being made available and how they're being made available to the research community to answer these questions. So there's a report of which this is effectively the first page of it. It acknowledges all the funders, mentions various people who are involved with it. And then there's always a table then about what data sets are being available in different countries, England, Scotland, Wales, and Northern Ireland. And you can see it's quite a complex table. I wouldn't go into it in any great detail because everybody will get a copy of the slides and they can have a look at that. But increasingly, the vast majority of the data are being made available. There are some issues with things like Pillar 2 testing. And again, we can see how many research studies and that are being used. In that previous slide, see, one of the things that was highlighted was the SAIL data bank. And so I'd like to just talk a little bit about that. I was involved, I wrote the original grant that led to the funding of this back in 2006. SAIL stands for Secure Anonymised Information Linkage System. It's funded by Health and Care Research Wales, part of the national research infrastructure. And what it is a privacy protected environment for de-identified data. And it has a whole bunch of systems in place to ensure that the data that are used cannot be identified by those who are doing the analysis. And people can look up, there's quite a number of papers on that. I'm quite happy to send them to people about how that works. One of the key components of it is public engagement, and there has been a group called the Consumer Panel. It seems a slightly dated concept at this point in time, that's been in operation now for 9 or 10 years, composed entirely members of the public, and they're involved in everything that we do, from bid development. They get to see every proposal that's put ahead, and in large numbers of studies, they're embedded in the studies involved in impact and dissemination. So a couple of months ago, my team were busy doing lots of work on multimorbidity, and along came COVID. And the first thing I did when that came along was to offer my team's support to the Chief Medical Officer for Wales, Frank Atherton. And very soon afterwards, I found myself on the Welsh Government COVID-19 Technical Advisory Group, which also feeds into SAGE. And in that, I lead the data linkage program for Wales. We adapted this philosophy of a One Wales approach, which is quite usual for us, created a multidisciplinary, multi-agency team. Below that on the slide, you can see all sorts of acronyms of organisations from academia, the NHS, government, clinical groups, statistics and mathematics, who come together to help in this initiative. And what we did was we leveraged essentially a lot of the development we were doing on a thing called the Wales Multimorbidity Cohort to create these cohorts to track COVID across the population and to help understand what was happening and to evaluate countermeasures. So again, it's a big team of people. I probably got about half of them to get access to their photos to put them up there. And again, what I'm going to point out, this is the work that this team has been doing. It's not me by any means. So in the COVID cohorts, what we've started with is to create a cohort of the entire population of Wales that were alive on the 1st of January 2020, and a counterfactual cohort of the same point, the 1st of January 2016, about 3.2 million people. We bring together data longitudinally linked, as you can see on the left-hand side, from many different data sets. And the ones on the right which are highlighted are, if you like, the new sources of data that have appeared quite rapidly for COVID. Come from many different sources, including the testing, GP systems, intensive care data, prescribing data, Zoe app data. I'll talk about that in a little bit. And very recently also being allowed to link in the 2011 census. And that was particularly important for us in work we're doing on the impact of COVID on the Black, Asian, minority ethnic group, because the coding systems within the routine data aren't good enough to do that properly. We also have now linked in electronic staff records and viral genomes and various other things. Just quickly, some analysis. Here's a daily analysis of emergency department data. You can see this massive plummet. The red dotted line is when the lockdown officially began on the 23rd of March. But you can see that the population self-isolated and stopped doing many things about 10 to 15 days before that. And even though some of the data is poor quality coded, it tells a very big story. And also you can see over time that that's all, the activities are starting to increase again. One of the things we've been doing for the Welsh Government Technical Advisory Group is creating these sort of analyses of what happens to patients, what sort of patients get affected, and how we can track them over time. So you have a diagram and how we've been doing that. It's a couple of weeks out of date now. It gets updated every week. They point out to you the survival curve on the bottom is some of the analysis we've been doing about what's happening in care homes in Wales. This is something we've gotten very wrong. What you're looking at there is the proportion of the population in each of the years in the top group prior to COVID, so 2016 to 2019, that they're the survival curves, if you like, for care home residents. And the green one is what happened after lockdown. So much worse survival, and as Adam said, much higher mortality rate. Another type of analysis going on is geographical analysis of people with symptoms, which is helping us enormously. And this is the Zoe KCL tracker app that a lot of people, over 3 million people in the UK, use. We have brought this into the privacy protected environment, and Peter Diggle and colleagues from Lancaster University have helped with some of the Bayesian smoothing maps. And that shows us how the sort of symptoms which are predictive of COVID disease are changing over time. And this is something that we update weekly and feed to the various groups. An important aspect of dealing with lockdown and understanding what's happening is to be able to longitudinally link data across sectors. We designed our system to anonymize individuals, to anonymize every household, and now we've built in systems that we also anonymize schools, care homes, and healthcare facilities. And we're starting some work now to understand how disease is transmitted between sectors, and also then to build in evaluations of interventions that are made to improve the situation. We do look at lots of different types of analysis. This is a dashboard which we can automate and update every week on years of life lost by men, women. This one is particularly looking at deprivation, and again, unsurprisingly, the deprived are affected to much greater extent than those in the affluent group. So I'm coming to the end of the talk now. This is my final slide. You know, COVID is pretty much a public health disaster. We look at the number of people who've been killed and made seriously unwell. Like all disasters, sometimes they have silver linings. COVID has accelerated data access and research in a way that I've never seen before. A lot more data sets have become available. They're more timely. Groups have seriously started to embrace team science, which is absolutely essential. There are a lot more multi-university collaborations and academic NHS collaborations. Much greater numbers and groups of different disciplines, a sort of a fusion of approaches that are being taken. And the result, it's about 2 weeks ago, I think, the UK group celebrated preprints on COVID-19. However, there is a lot more that needs to be done. It's interesting when you look at public health funding over the decades. There's a long history of crises which rescue an ailing public health infrastructure from oblivion. I'm hoping that the lessons that we learned from COVID-19 won't be forgotten too quickly. And I'll finish there and just say thank you for listening. Diolch yn fawr.
Okay, well, thank you both for two very thought-provoking presentations. And Adam, thank you for encouraging us to reflect on the lessons from the current pandemic, and for your very tangible suggestions about how researchers and scientists might be able to ensure that the data they have meets the needs of society. And Ronan, thank you for sharing some really interesting examples of how you and your colleagues are trying to do just that, to use data to meet the needs of society in this sort of current public health emergency we have at the moment. So I'd like to sort of move on now and have a discussion and put some questions and discuss some of the questions that we've had. So we might start with the first one, which is how do we manage the issues relating to data protection and confidentiality of health data, which is often a barrier to use of data to improve care? So how do we manage the issues related to data protection and confidentiality of health data so that we can break down some of the barriers to allow us to use it to improve care? Would either of you like to start on that one?
I'm happy to start on that. SAIL is an example, and probably the best example at the moment, of what's referred to as a trusted research environment, in which privacy protection and security has been thought about and designed from the beginning. We spent over 2 years planning how we would do that before we did it. And that helped people have confidence in sharing data. And we essentially haven't had any problems in what we've done. That was quite different to, if you like, the experience, if people remember, some years ago with care.data, when there was considerable public anxiety about that. So there are a lot of different design principles which are now being adopted in many different parts of the world, which can easily be taken up. So we should have a whole set of trusted research environments across the UK, and the ability to do federated analysis across them to be able to answer questions more quickly and not cause any public anxiety.
I add a few things, Jennifer, is that okay? I'm really glad that Ronan shared the approach that they've adopted in SAIL, which is definitely an example of best practice, and I think it's tremendously exciting what you've achieved. I suppose I just have one comment, which is really around kind of thinking about data protection as a barrier, and I see why people think about it as a barrier, because it's often experienced as one. But I just kind of like to unpick that a little bit more. And it seems to me that there are both supply and demand side issues here, and data controllers, so that the people who make the decisions about what data should be used when, often they do have some distance to go in terms of improving how they're working. The processes could be really clumsy. Questions around how the sort of risk tolerance and risk appetite of people who are making these decisions as well. But there are also some things the data teams can do to improve the way they use the current information governance arrangements. And one thing that we could all do is to engage better with the public, because data controllers say that when they receive an application that has had genuinely public engagement and there's a clear public appetite for the work, examples of patients championing the work, well, that application is a lot more likely to go through and be accepted. And likewise, we can all get a little bit better, I think, at thinking about the benefits of the work. I think the National Data Guardian is doing some important research in that at the moment, like how can we get better at articulating the benefits. So it's just, although this is a very frustrating area as a researcher, we spend so much time applying for data. I think let's not forget about some of the things that we can do ourselves just to make the process go a bit more smoothly and be more effective as well, and help better decisions be made at the end of the day.
Okay. Thank you. And there's a few questions sort of related to this topic coming through, and so we might sort of take the next one, which is I think slightly related and in the COVID situation, and perhaps a little more provocative. And that was, I was surprised that as a shielded person, in addition to a letter from the CMO, I received a message from Sainsbury's offering a prioritised slot for food deliveries. What happened to data protection in these circumstances? I don't know if anybody wants to comment on that at all, but it obviously takes the idea of data protection, data confidentiality a little further into sort of the current circumstance where things have been moving quite fast, and how we sort of really use data in a public arena.
I'm happy to come in here. I think you need to distinguish between the use of data in managing an epidemic by, if you like, the public health agencies, who are, if you like, tracking people, doing contact tracing and all of that, and with the use of data for research. So what I've been talking about is effectively de-identified data that we conduct research on, but we never know who the people are or where they live. I suspect what happened there, but I'm not absolutely sure, is that there was a great deal of urgency about alerting people who, from what we knew scientifically, were at the highest risk, and making sure that we were treated well. So letters went out to people, shielding population. It's important. There's a lot of research conducted to actually understand how well that worked or didn't work, and all the ups and downs in it. And I suspect that some of those groups then felt that if we are organising for people to be shielded and not leave their house, they may need to have food delivered. And I suspect that was probably a rushed idea that wasn't perhaps fully thought through.
I just think it shows kind of how the world is changing. I mean, I don't know the details about what's happened in that particular instance, Helen, but just isn't it interesting that you in your daily lives is being affected so much by the use of health data, and what does that tell us? And what kind of value judgments were made in this decision, and how, as a society, do we make sure that the values of our population being reflected when these decisions are being made? What does that mean for public engagement and debate going forward? I think these are really fascinating questions.
Right, fantastic, thank you. And let's move on to another question then. That's what is about collecting the right data at the right time, I guess. So how do you ensure that the right data is collected in the first instance? How do we know what data to collect? And I think, in your talks, you referred to things like missing data, for example, Adam, in your talk, and pieces, that one of the things that was the problem is missing, the data, things we don't have data on. How do we ensure that we collect the right data in the first instance?
Yeah, I think that's, shall I kick off this time, Ronan?
Yep.
Well, I think it's really fascinating. I mean, clearly within the context of a research study that involves primary data collection, we have quite a lot of freedom to design data collection, and can quite a lot of control over that. But increasingly, we're relying a lot more on data collections that are existing data collections, and maybe have been shaped by the digital systems that are being adopted within health and social care, and that's when things get a lot more complex. I think what it comes down to is really about who the data is being collected for. And maybe I could just sort of share a few findings from the work that we've been doing with Future Care Capital on social care, because it's such an interesting kind of example. We've been engaging quite a lot, well, a little bit with social care users to ask them what they want to get out of the social care system. And I wouldn't pretend to have data on a representative sample of social care users. We've just engaged the best that we can over the last few weeks. But what quite a lot of individuals are saying is that they feel like the data is being collected for the purposes of the management of the social care system, as opposed to for the purposes of helping people to live healthier lives and achieve their personal goals. And if that's true, that's quite a provocative statement that has quite a lot of implications, I think, for how we build a data system going forward. And it does open a whole bunch of questions really around public deliberation and the design of data systems. And there are some various tools and solutions here we could explore further, data institutions, data trusts, for example, being one of them. It's a really difficult and really complex question.
Do you have anything to add at all, Ronan, to that?
Yes. Amazingly, I think you see the data that we largely use are people call it secondary uses of data. So they're data that have been collected for other purposes. I mean, I've gone on for a long time without having much impact about the fact that the vast majority of data collected by the health service is really about management functions and not about patient outcomes and experience. And we really need to reorientate what we do to primarily be interested in people's outcomes and experiences. And that way we would get the data right, and we would have the data that we need to answer the appropriate questions.
Great. Yeah, no, those are some good points. Thank you. So we've got a question now that relates to the methods that we use around data. So the next question says, first of all, to both of you, thank you very much for your presentations and commentaries. And are there examples of machine learning methodologies being used to automate data analysis and outputs that you can tell us about at all? Do you have any examples of machine learning that might illustrate the possibilities of machine learning methods in the context of health and social care data?
So you have some, Ronan.
Me? Okay. So yes, I haven't any examples just about this particular one, but in general, there's a huge amount of investment and time going into machine learning, artificial intelligence, and that. Various different ways, sometimes just about summarizing, exploring and visualizing data, and then sometimes about looking for patterns in the data which we don't come up with our logical reasoning. So there's an awful lot of work being done around the country on that. There are many different examples. So there are groups, for instance, looking at automated reading of chest x-rays. So before a radiologist has even reported that you can take a chest x-ray, have it analysed, and the predictive aspect of that as to whether this is likely to be a case of COVID. Many, many different ones doing. That particularly, I would say, the two groups involved in this are the Alan Turing Institute group and then the Royal Society Delve initiative, with a lot of mathematicians who are adding new vigour and new methodologies as we are moving on.
Okay. Did you have anything to add on, or shall we move on?
No, let's move on.
Next question. Okay, thank you very much. That's great. Thank you. So I think this comes back a little bit to thinking about the data and how we collect it, and back to the COVID situation. But the next question is, with COVID-19 being a very popular topic, obviously, at the moment, and many people trying to collect data rapidly, I guess. Unfortunately, not all the data is high quality. Do you think we need to control the quality of the data, and do we need a policy to control this? I guess that's probably in the particular situation of COVID, and I suppose logically, how might we do that?
Well, over the years, we've had endless data quality initiatives. People working in the NHS and other can do that. One thing I find is that when data are used, the data quality improves. So I'm not a person who will always wait for perfection before start to use things. Start to use data and improve them, build in feedback loops and incentive loops. Really good quality data is necessary for the operation of any organisation. The NHS has not invested enough in that in the past. Social care is woefully behind on that for a variety of reasons, but really needs to be brought up into the 21st century.
Yeah, I mean, I completely agree. And I find it a really hard concept to talk about, in part because there are so many different ways to think about quality. I think about this quite a bit when we use GP data. That data was collected first and foremost for the provision of clinical care, and who am I as a researcher to tell a GP whether the data they're collecting and recording in patient notes is high quality or not? I mean, it's a very strange kind of concept in some ways. So I think it depends on what it's going to be used for. Clearly, in the context of COVID, this is particularly difficult question. And we're all trying to move very, very quickly. So I think I would my expectation would be that teams publish data necessarily that isn't perfect quality, but need to really describe very carefully how the data are put together and what the potential limitations are, so they can be understood, and we can be working to improve the quality over time. Perhaps that kind of approach might be suitable. It's a tricky one.
Yeah. Thank you. Yeah.
Ronan might have further thoughts.
Yeah, I mean, one thing I would add to is we do really need to move into the 21st century. So coding is a sort of bizarre concept if you think about it. So if you're there as a clinician and then in the end you're interfacing with something to give you ICD, SNOMED, READ or whatever codes. The reality is that we should have or be moving to really good quality speech recognition that allows algorithms behind that to code data in almost an infinite number of ways that can then be nuanced to answer the questions that we need. If you look at GP data, there are 300,000 read codes, and I know we're moving to SNOMED, in which there's even a large number, but the interfaces for coding are clunky things that are well past their sell-by date and need a lot of improvement.
Great, thank you very much. So you both alluded to the involvement of patients and members of the public and the importance of that in terms of sort of data collection, data management, data research processes and so forth. So we have a question here about that, and that is how could we encourage public and patient involvement in as it relates to data research? Do we need to train up lay people, and where should they be involved? So maybe I could invite you both to speak a little bit more about patient-public involvement in these processes. So who would like to go first?
I'm happy to share a bit more about the journey we've been on. So
that'd be great, thank you.
We've got a data team in the Health Foundation. We've been running for 5 years, and we haven't been where we should be when it comes to patient-public involvement and engagement. But we are really trying to challenge ourselves to improve our practice on it, and I sort of linked to the week notes earlier that tells you a bit more about it. One of the things we found was that, and I hope the team won't mind me saying this, is that it can be a bit scary if you're not used to doing this, to start talking about with patients about your work, and there are all kinds of fears that come up. A common one is that people think that patients will tell them their work is irrelevant, or they'll point out some major problem with the work that perhaps hadn't been realised. They'll say you're working on the wrong issues. There are many different fears that come up. But what we found is that we just have to start speaking to patients and the public about the stuff that we're doing. Supported conversations with individuals have been terrific. I've learned so much from doing that. We've developed some resources that we're beginning to use as a team, 13 ways to involve patients and the public in our work. And we hope to share those resources soon in case other teams use them. Engagement possible at all kinds of different levels. I do think it's really exciting. And it does lead to quite a different work program when you do this well. And I think a much better product at the end of the day.
Yes, no, I couldn't agree more. I mean, if I just talk about the project we're doing at the moment, at the design phase, we brought it to that consumer panel and members of the public to discuss it with them, engage with them, and they helped shape it. It got assessed by members of the public. Since we've started, we've recruited 2, and we're going to recruit another 3 members of the public to sit on the steering board to make sure that we address any concerns they have and also answers questions that they have in their head. With research funding, it's always interesting that the research funders are always looking for novelty. But very often when you're talking to members of the public, they don't want novelty. They want actually very ordinary questions answered. And so you have to be able to do both to be successful in what we're doing. We do it for virtually every project we're involved with. And I'd like to see that being used a bit more widely. It's great to see public involvement in a lot of the funding panels. I sit on one at the moment, and every project is assessed by 3 people, 2 scientists and 1 representing members of the public. And I can tell you that if you don't address the issues that the public feel need to be addressed, the chance of being funded is nearly nil.
Okay, yeah, very interesting, thank you. I think we'll try for another question, I think, that's come through on the topic of interpreting data correctly and presenting it and using it appropriately. So this question says, I've started reading Dave Spielhalter's book on statistics. One of the things he preaches is about interpreting data correctly and presenting it in an open and transparent way that is analysed objectively. How do we get to that place? A bit of a nirvana, I guess, but how have you got any comments or thoughts on how we might get to the place where we can really interpret data well and make sure that it's used in a transparent way?
Well, I think I could add anything to what David Spielhalter said in that book. I mean,
that's fine. That's fine. Just to agree, it would be great. It would be great if we could do that.
So maybe Ronan's question.
Yeah, no, I agree very much where he's coming from. So transparency of what we do and the replication, reproducibility of research is really important. And we should always produce the methodology to the detail that somebody else could replicate it. I think that's important. You also have to think about what angle people are coming from when they're answering questions and what questions they're answering. And it's very easy for people to look at pieces of research and think it's answering a particular question when it's answering something else. So I think clarity about what is being answered and what is not being answered is also important in people's understanding.
Okay, thank you very much. So I think probably at that point we are running short on time and we need to start to draw things to a close. So I'd like to thank everybody for the really huge number of questions on quite a diverse range of topics that we talked about. And I apologise we didn't manage to have time to ask everybody's questions, but I think we touched on most of the topics and themes that came up through the questions, which is really great. So I'd like to draw the plenary to a close, and I'd like to thank both of you again very much for speaking with us and sharing your presentations with us. And also again, the audience very much for their questions and also for attending this virtual plenary. As you know, this was the last of our live plenaries, and I'd like to thank again the Health Foundation and the Nuffield Trust for their support for Health Service Research UK and for the conference that's enabled us to come together as a community in this way at this sort of challenging time. Please do carry on the conversations offline and tweet using the hashtag HSR UK. And remember that also a recording of all the plenaries can be found at our website, along with the many, many recorded sessions and presentations that have been given as part of this virtual conference. It's been a really packed 3 days, so if you have missed anything, please do go to the website and take the opportunity to look, because there's been some really interesting presentations and sessions available virtually on the website. So we hope very much that you've enjoyed the conference, and we very much look forward to being able to see you hopefully in person at a conference next year. But for now, goodbye. Thank you.